everything all right. Door in, door out time, 53 minutes. Really, I still say that's really good. Reaching that 30-minute cutoff is not that easy here. Close. Case 5, 67-year-old chest pain, radiating to the arms. Tachycardic, blood pressure a little bit high here. The hospital was pre-alerted with this STEMI. Patient had lytic therapy and transferred to us, door in, door out time 76 minutes. Really, really good, I think good work overall here. And so the EKG, seeing a lot of these inferiors here. So let's see what the interpretation said. Abnormal EKG unconfirmed. Inferior infarct, possibly acute. I think that's fair enough. I would say probably acute. But, let's see, what did this one say? Abnormal anterior infarct.
Well,
Is that the right side?
that's
Oh, this is the right side.
the
Okay.
V4R.
Sorry.
So
Yeah,
V4
that's right.
is V4R actually.
Yeah, okay.
And I know it doesn't look like there's
Not really
anything there.
diagnostic. Thanks for catching that. First EKG at arrival here. This still looks worrisome here out in 3. It's weird that AVL. Oh, wait a second. How are these leads placed? So this is weird. These are,
Oh, wow.
so yeah, these are out of order. So here's lead
I've
1.
seen that before, that is so bizarre.
How did that happen? Here's leads 2. So 2 and F. 3. So, yeah, I've never seen that. I don't know how you do that. Is there a button you hit on the machine to do that?
There must be.
I don't know what they did at St. Vincent there. But, so this patient had a clotted LAD. Interesting. It's still, it's open by this time, but there's a chunk of clot right here. And that got a stent. So this is a little weird presentation for an LAD event, I have to say. Sometimes they throw some knuckleball like that. So pain-free, persistent ST elevation, LAD, let's see, high ejection fraction, 80-85%, no almost stenosis. So first medical contact to intervention, 187 minutes. St. Vincent, sometime we got the patient to intervention, 36 minutes. So these are some of the time things that Marla will be sending back to let you know how things went. I think this, we're almost done here. 59-year-old woman, severe chest pain between the shoulder blades, dyspnea, little bradycardic, fast respiratory rate. EKG showed a STEMI, lytic therapy, transfer time 115 minutes. Here's the EKG, pretty dramatic. So again, inferior, first degree AV block, reciprocal changes, posterior extension. Seeing a lot of those. EKG at arrival, better. Lytic therapy really helped this patient. Declined cardiac catheterization. They discharged the patient without studies. We don't know what's going to happen. You may see her again. Whoever knows her, be on the lookout.
Go back, I think she was pretty young. Did I get
59.
59, yeah.
Yeah, they should keep a little card on your dashboard. People who decline catheterization. So I think Marla had just threw a couple of EKGs here. Watch the STEMI evolve, number 1. So here, it looks a little worrisome. You have this anterolateral ST elevation that would qualify. Inferior. No
How
reciprocal
old was
changes
she
though.
again? She's a 30-year-old, so this
Only
is a walk-in
30.
at triage at
30 years old. That's a tough one. You know, you're going to call that a 30-year-old get on a helicopter. And then look at that.
Oh, same patient?
Same patient.
I'd say she deteriorated quickly.
So one could say that this looks like ventricular to me. So this looks like idiopathic, idioventricular rhythm. Slow
So you think it's
ventricular tachycardia. Yeah, it's slow VT.
Okay,
Reperfusion, could be reperfusion VT.
that's what they called it, yeah.
Yeah.
So this is after lytics?
No, this is actually a patient who walked in at St. Vincent.
What's the time difference?
So,
You can tell right there. So
maybe
it's
she was like
8:35,
stuttering, you know?
8:35, 8:52. But that's acute dysrhythmia. That's not the EKG dysfunction, because here's 30 kg. Now she's going to cath lab. Still having that. Look at that. Now it's worse. Looks worse to me.
So V2 through V6 are
Yeah.
all elevated.
Yeah.
So what arteries are going to be? I guess.
Left descending?
Right. That's what I'm thinking. So This is an interesting case, because this is unusual. Here's their left anterior descending artery, and see what happens right here? It becomes string-like. Opens up, my partner put in 2 stents here. And this lady's ST elevation didn't go away, by the way. I mean, when she was in the hospital, it didn't improve. It made me wonder about the spontaneous coronary dissection. We do have young women who seem to be prone to spontaneous coronary dissections of left anterior descending artery when they don't have atherosclerosis or risk factors. You see this configuration, you're really worried about dissection. It can happen postpartum or peripartum when people strain and have babies, that kind of thing. Sometimes you see that kind of problem. I don't have enough history to know about this lady, but that we've seen this a number of times, usually in women. Seen it in the right coronary and seen in the LAD. And let's see, that was it. Oh, and you have one final EKG here, just to show a lung cancer patient. This patient had normal wall motion. So sometimes the echo, sometimes when they show up in the ER, we don't know what to do. We have the advantage that we can get an echo and a stat read right away. And we see this kind of ST change with no wall motion abnormality, or we see a little pericardial fluid, then in a patient with cancer, then you know that's going to be pericarditis. And so all the signs here, you see the PR depression, you see diffuse ST elevation, no reciprocal changes, normal QT interval. I think that's all I have for you. Okay, we got them all down. Thanks for bearing with all those cases. That's a lot. It's like 25
That's great.
cases.
More the merrier.
Thanks for coming down.
Okay, a question for you is, we see some where there's not really a distinct J point. They're more rolled J point. But they look
like this? Or
yeah,
like this?
no, it's they look like elevation, but they're rolled. So you're trying to figure out, is the J point? Is there a distinct J point in there somewhere? What do we do? Split the difference? Go between.
I think repeat EKG often clarifies that. So history, repeat 12 lead, on around those things usually clarify them.
Okay.
If the patient's history is good, and you see that, then go with it. But if the patient's, oh, it hurts when I cough, and see that kind of thing, or if they're young, and, that's one we might get an echo in the ER to try to sort it out.
Okay.